بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. Inshallah, today we are going to have second part of Pediatric Endocrinology Review MCQs. My name is Abdulmoein Al-Agha, Professor of Pediatric Endocrinology, Faculty of Medicine, King Abdulaziz University. 14 years old girl, known case of type 1 diabetes for the last 4 years. She started to complain from repeated attacks of hypoglycemia, malaise, fatigue, and weight loss. Which one of the following is the most important investigation you are going to order? So we have a type 1 diabetes, and this girl new complaint of repeated attacks of hypoglycemia together with weight loss. Hypoglycemia and weight loss, fatigue, malaise, all these symptoms. What do you think? What other association with type 1 diabetes could explain these symptoms? Let's go one by one. Number A, measurement of acute phase reactants. Yes, it could be something acute, but the scenario does not support this as a good choice. Measurement of cortisol and ACTH hormone. Yes, very good thinking of Addison disease. Addison disease is associated with type 1 diabetes, and all the symptoms mentioned in the scenario goes with Addison disease. Thyroid autoantibodies, it is the opposite. If we have Hashimoto thyroiditis, the patient will not suffer from weight loss, the opposite, weight gain, but they will suffer from malaise and fatigue, but they will not suffer from the weight loss. Measurement of C-peptide for possible honeymoon phase. Honeymoon phase will not come after 4 years of diagnosis. Honeymoon period usually started within 1 month of diagnosis and will not start after 4 years of diagnosis. Primary adrenal insufficiency, Addison disease. The clinical features including fatigue, nausea, vomiting, hypotension, dehydration, electrolyte abnormalities in the form of low sodium, low chloride, high potassium, metabolic acidosis, and these patients sometimes they can come seriously with adrenal crisis. The most important manifestation of Addison disease is unexplained hypoglycemia and unexplained weight loss. So the patient, despite his having diabetes with good control, started to have repeated attacks of hypoglycemia unexplained. Also, they could have anorexia and weight loss. And I remember one of the cases I've seen in my practice, a girl comes with anorexia only, and she was not diabetic, but she was only having recurrent episodes of fatigability and anorexia. And she has seen many of the doctors, and initially they diagnosed her as anorexia nervosa. But unfortunately, when she comes to me, I thought of adrenal insufficiency. When I did for her, cortisol level was low, ACTH was high, so the anorexia, unexplained anorexia, was not psychogenic, was because of Addison disease. So you have to think of Addison disease whenever you have a girl or boy, but commonly in girls, with unexplained chronic or for long period of anorexia. Usually in Addison disease, 8 a.m. cortisol level will be low, STH will be high, but we need to confirm by doing short synectine stimulation test. We need to confirm it, not to depend only on the basal level of low cortisol. Newborn with genital ambiguity, noted to have generalized hyperpigmentation. So here we have a baby, newborn, ambiguous genitalia, and generalized hyperpigmentation. When they did ultrasound of the pelvis, they found presence of both ovaries and uterus. What is the most useful investigation? Of course, the scenario goes with congenital adrenal hyperplasia, straightforward of congenital adrenal hyperplasia, but the question, what was the most important or most useful investigation? Testosterone, yes, we know testosterone will be high in congenital hyperplasia. 17-hydroxyprogesterone will be high. Serum electrolyte is very important in congenital hyperplasia, as well as dihydroepiandrosterone sulfate. So all of them is true. Sometimes you face in the MCQ one of the questions like this, and everybody will be surprised. They said all of them is true. Yes, but when you look to the statement, what is the most useful? You know, congenital hyperplasia, most useful investigation is 17-hydroxyprogesterone. Despite all of them is okay, all of them is important, but if you asked to select one very useful or most useful, 17-hydroxyprogesterone is the most useful investigation. Congenital hyperplasia, autosomal recessive disorder, over 95% of cases due to 21-hydroxylase enzyme deficiency. That's why we need always to remember 21-hydroxylase enzyme deficiency is the commonest form. In many countries, including, alhamdulillah, المملكة العربية السعودية, neonatal screening for congenital adrenal hyperplasia is done for all babies. And remember, we might have 17-hydroxyprogesterone is the main screening test. Sometimes we have false positive high 17-hydroxyprogesterone. So whenever you have a screening test for congenital hyperplasia by doing 17-hydroxyprogesterone is positive, never depend on one sample, you have to repeat it, and you have to exclude the other causes of false positive. Number one, if this test was done within 48 hours of life, it will give you false positive. So we should do the screening from day 3 to 5 days of birth, not in first 2 days of birth. Number two, we have to be sure that the baby is not sick, because if the baby is sick, the test will be false positive. And we have to be sure that the mother during pregnancy was not taking any steroid, because that will impair the result. 10-day-old boy presented with hypertension and metabolic alkalosis. He was diagnosed with congenital adrenal hyperplasia. So this is another scenario of congenital adrenal hyperplasia where we have the opposite of the usual. What is the usual in congenital hyperplasia? The usual is low blood pressure, hypotension. The usual in congenital adrenal hyperplasia is hyperkalemia. Here the opposite. Here we have hypertension instead of hypotension. We have hypokalemia instead of hyperkalemia. And we have metabolic alkalosis, which is not the usual. The usual is metabolic acidosis. But this patient is actually congenital hyperplasia. It's not by mistake labeled as congenital hyperplasia. So we have to think of something not the usual, not 21 hydroxylase enzyme deficiency. The usual is 21 hydroxylase enzyme deficiency in 95% of cases. Here, something else. Is it aldosterone synthetase deficiency? No, because aldosterone synthetase deficiency will give you low aldosterone. Here, alkalosis, metabolic alkalosis, hypertension, for sure, the low aldosterone will not give you high blood pressure or metabolic alkalosis. 21 hydroxylase enzyme deficiency, for sure not. This is not the manifestation of 20 hydroxylase deficiency. This is the opposite, completely the opposite finding. 3 beta also no, because 3 beta hydroxysteroid dehydrogenase deficiency will give you high block, will give you all the product is low aldosterone, low cortisol, low sex hormone, so definitely not 3 beta. So we left up with 17 hydroxylase deficiency. Let's say in 17 hydroxylase enzyme deficiency, what will be the scenario? Here, if you look into this steroid pathway, you find 17 hydroxylase enzyme deficiency is considered to be high block. When 17 hydroxylase enzyme deficiency is present, the first pathway end up with aldosterone is completely normal. Nothing will be happen because 17 hydroxylase enzyme is not one of the enzymes responsible for aldosterone synthesis. So here we'll have normal or even high aldosterone synthesis, because when we have the block of 17 hydroxylase, the second line, which is cortisol synthesis, will not happen, and the third line will not happen of the sex hormone. So the XY baby, the male, will have ambiguous genitalia, not the female. Here in this enzyme, ambiguous genitalia in a male, what is called 46XY-DSD, disorder of sexual differentiation in a male. Ambiguous genitalia in a male rather than in a female, together with low cortisol and accumulation of aldosterone metabolite. 17 hydroxylase deficiency is rare form of congenital adrenal hyperplasia. So despite we need to memorize 21 hydroxylase enzyme deficiency by heart, because it is a far most common enzyme deficiency, but still we need to think of other rare enzyme, because in clinical practice, not always you face the common, sometimes you face the rare form. You have to be aware of 17 hydroxylase enzyme deficiency. As I mentioned, in 17 hydroxylase enzyme deficiency, the production of glucocorticoids and sex steroid will be low, resulting in cortisol deficiency as well as 46XY-DSD. In the opposite, the axis of aldosterone will not be affected, and all the metabolite will be shifted to this line, the line of aldosterone, resulting in excess of or increase synthesis of mineralocorticoid precursors, resulting in hypertension and hypokalemia. Here the treatment is by giving cortisol replacement, and when we give cortisol replacement, we'll suppress the production, we'll suppress the ACTH, and suppressing the ACTH will suppress the formation of excess metabolites, leading to excess aldosterone synthesis. 6-month-old 46XY infant presented with non-palpable testes. So both testes were not palpable, despite the genitalia is completely of normal male. Which one of the following is the most appropriate next step to do? Number 1, assure and re-examine him again in 18 months of age. This is true if we have one side not palpable, if we have unilateral undescended testes. And this is the usual practice. In unilateral, we assure the family, most likely it will be descending with time, and maximum waiting time is 18 months. After that, if not descended, surgical operation to get it down, or P.O.Box. So number one is for sure wrong for bilateral undescended testes, but it's completely right if we have unilateral. Number two, refer the patient for exploratory laparotomy. This is completely wrong. We cannot, from day one, we didn't find both testes, we sent for surgery. This is completely not true. Measure basal and HCG stimulated testosterone and dihydrotestosterone. This is completely right, and this is the practice because we don't have both testes palpable. They are intra-abdomen. We need to be sure that are they functioning or not functioning. And when we do HCG, human chorionic gonadotropin stimulation, we stimulate the leading cells of the testes to produce testosterone. So when we do HCG stimulation test, to be sure that we have both testes are present and functioning. Not only present, we need to be sure are they present and are they functioning or not. So this is the proper answer. Start therapy with testosterone enantioate 50 mg IM monthly for 3 months. This is not a treatment of undescended testes, this is a treatment of micropenis. Cryptorchidism, the medical terminology for undescended testes. Usually, من رحمة الله, cryptorchidism is unilateral. One testis only, not getting down in the scrotum. It may be secondary, cryptorchidism may be secondary to endocrine disorders, may be secondary to genetic syndromes, may be secondary to embryological abnormalities, particularly if they are bilateral. Unilaterally, usually normal neonate have unilateral undescended testes. This is normal, usually has nothing to do with any of genetic syndrome or endocrine. But whenever we have bilateral undescended testes, this is a serious problem. Don't ignore it. And I remember one of the residents in the past ignored our child, a baby with bilateral undescended testes, discharged home after 24 hours of life, thinking that undescended testes bilaterally is the same as unilateral undescended testes. Different. Whenever you have unilateral undescended testes, this is normal finding. Not normal finding, I mean not serious finding, but bilateral undescended testes is a serious problem. We have to investigate. We don't leave it. We don't reassure the parents. We don't discharge the patient unless we know what is the underlying cause of bilateral undescended testes. Bilaterally, non-palpable testes in phenotypically male require immediate evaluation. There is nothing to discharge and say, okay, see you after 3 months in the clinic, follow up in the clinic. No, should be immediately evaluated at birth because of many of differential diagnoses, including of disorder of sexual differentiation. Disorder of sexual development or differentiation, the terminology is D, including children with mixed gonadal dysgenesis, children with ovotesticular disorders, persistent Muller-Index syndrome. This one should be in the list of any baby born with bilateral undescended testes. Neonate was born with abnormal neonatal thyroid screening done at 3 days of age. Remember, neonatal screening should not be done in first 48 hours of life, whether it is for thyroid, for congenital dysplasia, for metabolic diseases. The best time of screening is between day of 3 to day of 5. So this child or this neonate had the neonatal screening at day 3, and the result was free T4 was low, TSH was high. So we are dealing with congenital primary hypothyroidism. Congenital primary hypothyroidism. The question is, which one of the following might be the cause of congenital primary hypothyroidism? If you read my lecture notes, you find that most common cause of congenital primary hypothyroidism is thyroid dysgenesis. Thyroid dysgenesis. In central hypothyroidism, we find both low. Free T4 low, TSH is low. TBG deficiency, thyroid binding globulin deficiency, is very rare. It's not the common cause. That's why in the statement, which one of the following the most important cause? Hypothyroidism from excess iodine exposure. This is true, causing hypothyroidism, but not the most common. So what happens that in nursery, in an ICU, whenever we do umbilical cord catheterization, for septic reason, we need to clean the area with iodine. And too much iodine, which is the usual practice and correct practice, we don't change the practice. The iodine might be absorbed from the skin of the baby because, as you know, the neonate, especially the prematures, their skin is very thin. Immediately they will absorb the iodine, and when they absorb the iodine, the excess iodine will suppress the thyroid hormone synthesis, result in neonatal hypothyroidism. But also, this is not a common cause, despite it is a true cause, but not the common cause. The common cause of congenital primary hypothyroidism is dysgenesis of the thyroid gland. Congenital hypothyroidism, as I mentioned, thyroid dysgenesis or agenesis is the commonest cause of congenital primary hypothyroidism in almost 90% of cases. The prevalence of congenital hypothyroidism is 1 to 4,000 births. Clinical manifestation of hypothyroidism: baby will be having decreased activity, large, widely opened anterior fontanelle, poor feeding, poor growth, prolonged neonatal jaundice, or yellow skin. What is the difference between yellow skin and prolonged neonatal jaundice and jaundice? Jaundice will involve the skin and mucous membrane, while yellow skin is only skin is yellow. Mucous membrane is not yellow. So in hypothyroidism, congenital hypothyroidism, we might find only skin is yellow, or we might find skin and sclera, both of them are yellow, that is jaundice. We might have constipation, hypotonia, and hoarse cry. Remind you that we don't need to have all these clinical manifestations in order to do thyroid function test as a confirmatory for hypothyroidism. Presence of one of them is enough to do thyroid function test. And also remind you, one of the problems of neonatal screening, we do in Saudi Arabia TSH screening. We do only TSH in the screening. If TSH is normal or low, the lab technician or the lab doctor will not call the family to repeat the thyroid function test. So many of the central hypothyroidism are missed because we are screening only by TSH. So clinician should be examining every neonate. If the resident or junior staff examined the baby and found one of these finding, please do thyroid function test because this child might have primary or secondary hypothyroidism. And this is why we do TSH screening day 3 to 5, because as you can see in the graph, in the first 2 days, first 48 hours, TSH will be high, sometimes reach up to 60 microunit per ml. So we might have false positive thyroid screening. In order to avoid false positive neonatal thyroid screening, we need to do the screening from day 3, day 4, 5, 6, after 48 hours of life, not within 48 hours of life. This is the classical picture of a baby born with congenital hypothyroidism. What you could see, could you tell me what you are seeing now? If you can see, there are coarse facial features. The facial features is coarse, large tongue, brittle hair, abdominal distension, umbilical hernia, and hypotonia. All you could see it in the photo, in addition to yellow skin. We could not see from this photo the sclera. If the sclera is yellow, so jaundice. If the sclera is not yellow, we have a yellow skin only. All are features of congenital hypothyroidism. A preterm baby, 28-weeker, with birth weight of 1.2 kilogram. So here we have extreme premature. What is the definition of extreme premature? If we have a weight less than 1,500 and gestation age less than 32 weeker. Here we have a 28 weeker, birth weight is 1,200 gram. Thyroid screening showed low T4 and low TSH. So we have like picture like a central hypothyroidism. Which one of the following is most accurate statement? So please always look to the question statement, what the question or what the doctor asks you. Here the question most accurate statement. Number 1, A, hypothalamic pituitary thyroid axis immaturity. So is it low free T4 and low TSH because of hypothalamic pituitary thyroid axis immaturity or not? We'll see. B, hypothyroxanemia of prematurity needed short-term thyroxine replacement. This is wrong. 6, sick euthyroid syndrome. Could be differential diagnosis, but in the question didn't tell us whether the baby was sick or not, so we could not judge from the question. Abnormal thyroid function due to application of iodine containing antiseptic. All what has been mentioned is true, is accurate. So what do we choose? Which one we choose? The question said most accurate. So the most accurate is A, hypothalamic pituitary thyroid axis immaturity. This is exactly what happened in extreme premature. If we did for them thyroid screening, we find both of them is low. TSH is low, free T4 is low. What is called hypothyroxanemia of prematurity. So premature infants, they are liable to have low thyroxine because of low TSH stimulation, and that is called hypothyroxanemia of prematurity. In the majority of extreme prematures, T4 would rise into normal range when a second or third screening test performed 2 to 4 weeks of age. So these extreme prematures, if we did For them, the first screening at 3 days of life, after 48 hours of life, we find it abnormal. If the abnormal is low free T4, high TSH, this is hypothyroidism. But if we find both T4 low, TSH low, we have to repeat again at 2 to 4 weeks of age because of possibility of hypothalamic pituitary thyroid axis immaturity. So what's the recommendation for thyroid screening test for extreme premature? The recommendation in many countries, we do 3 screening tests for thyroid. First test after the 48 hours of life. The second test 10 to 14 days of life. And the third test 4 to 6 weeks of life. But the good thing, or the important thing, this infant don't need to have thyroxine treatment if clinically having no clinical manifestation of hypothyroidism, which I have mentioned previously. 13-year-old girl presented to orthopedic clinic with 2-year history of limping in her left leg. So here we have a limping. Limping means orthopedic, but we are endocrine review course. So we have to think that what an endocrine issue might be involved in orthopedic, like a limping. She was diagnosed previously with hypothyroidism, but the problem, this girl, she's not compliant on her thyroxine. By examination, she has short stature and she is obese because she has hypothyroidism and not compliant with thyroxine. As well, she had a limitation of movement in her left hip and she is limping. So what is the relationship between hypothyroidism and limping? And this limping, remember, she's complaining of limping for the last 2 years. So there is a 2-year history of limping. So that is chronic, it's not acute. Number 1 is slipped capital femoral epiphysis. Skiffy, yes, this is the accurate answer. Chronic osteomyelitis, this is not a good answer because chronic osteomyelitis will not come only with limping. Will come with fever, with a lot of problems, especially 2 years of limping. Chronic osteomyelitis for sure is not the differential diagnosis. Vitamin D deficiency never come in one side, never come with limping. It comes with bone pain, but not come with 2-year history of localized pain in left hip and with limping. Monoarticular rheumatoid arthritis, yes, but has nothing to do with hypothyroidism. So the most likely diagnosis is SCFE. SCFE or slipped capital femoral epiphysis, characterized by displacement of capital femoral epiphysis from the femoral neck through the physial plate. Usually, the main age of presentation in girls 12 years and above, in boys 13 years and above. Obesity is major risk factor. Hypothyroidism is another major risk factor. Growth hormone deficiency is the third major risk factor. Usually, the scenario in SCFE, the children present with chronic, intermittent, not radiating, dull aching pain in the hip region. And of course, the diagnosis by doing X-ray. But remember, when you order the X-ray, it should be frog position X-ray. The X-ray should be done in frog-like position, not the usual AB or lateral view X-ray. And this is the finding. The arrow, the red arrow, the yellow arrow is the normal, and the red arrow is the slipped capital femoral epiphysis. 8-year-old girl presented with goiter together with high TSH and low free T4. So this is like a child with hypothyroidism. But here in the question, they add that this child or this girl, in addition to hypothyroidism, she has sensory neural hearing loss. So you have to think, what's the relation between sensory neural hearing loss and hypothyroidism? What do you think? Yes, most likely you are thinking of Benderet syndrome. Correct answer, Benderet syndrome. So the question, what was, he didn't ask you what is the diagnosis. He asked what is the mode of inheritance. Benderet syndrome is autosomal recessive disorder. Autosomal recessive disorder caused by mutation of SLC26A4 We don't care about the name of the gene, but it is genetic mutation. This genetic mutation causes defect in organification. You know, if you look into thyroid hormone synthesis, you find one of the steps of thyroid hormone biosynthesis is something called organification of iodine. What is the meaning of organification of iodine? It is incorporation of iodine into thyroid hormone. So the combination of iodine into tyrosine molecule of thyroglobulin leading to monoiodotyrosine and diiodotyrosine is defective, so will not have any thyroid hormones production or synthesis because of this defect, leading to hypothyroidism, goiter, and in this syndrome it is associated with congenital sensory neural hearing loss because of this gene defect. So whenever you have a combination of congenital bilateral sensory neural hearing loss together with goiter, together with hypothyroidism, please think of Benderet syndrome. 12-year-old girl has presented with exophthalmos and weight loss. So this is very important manifestations of Graves' disease: proptosis, exophthalmos, weight loss. The question is what? Which one of the following is most likely cause for her exophthalmos? Why in thyrotoxicosis there is exophthalmos or there is proptosis? What do you think? Is it due to fat tissue deposition? Is it due to ocular muscle hyperplasia? Is it due to inflammatory infiltrate? Is it due to globe enlargement? All these could cause exophthalmos in any person, but in those with the Graves' disease, inflammatory infiltrate is responsible for exophthalmos. Graves ophthalmopathy, there is a feeling in the eye. Those with Graves ophthalmopathy, they feel something in their eyes, like there is a sand in their eye, gritty, foreign object sensation in their eye. They keep having this sensation. And also they have excessive tearing, they have pain in the eye or retroorbital, they have blurred of vision, diplopia, and sometimes they decrease vision. All manifestation of Graves ophthalmopathy. And this is the histological picture when they took muscle fiber biopsy and they look under microscope. What they found? They found that, of course, in child with Graves' disease, they found loss of striation, fragmentation, and infiltration with chronic lymphocyte, T lymphocyte. So this is immune-mediated inflammatory response. This is the reason of exophthalmos in Graves' disease. And this is how they look like. In addition to proptosis, what else you could see in this photo? Please tell me. Yes, we have proptosis. We have something called staring look, and we have a lid retraction. All are signs of Graves' ophthalmopathy. 13-year-old girl presented with history of loss of weight, dizziness, palpitation over the past 2 weeks. On examination, she was warm, tachycardic, and heart auscultation with audible with hemic murmur. All these manifestation of what? This manifestation of Graves' disease. But the question was not, what is the diagnosis? The diagnosis is Graves' disease. But they ask you, which one of the following investigation is useful in establishing diagnosis? Diagnosis of what? Diagnosis of Graves' disease. So the question, which one most useful investigation? So what do you think in Graves' disease? Do you think that they have positive thyroid stimulating antibody? Yes, this is the most useful diagnostic test for Graves' disease. Ultrasound scan of the neck is good, but it's not diagnostic. So what? If you find a goiter, it will not tell me this is Graves or not. Thyroid function test, yes, important. Anti-thyroid peroxisomal antibody, yes, important, but the most important investigation to establish the diagnosis of Graves' disease is thyroid stimulating antibody. Graves' disease, everybody knows that the commonest cause of thyrotoxicosis, and everybody knows that the reason behind thyrotoxicosis is the presence of thyroid receptor anti-stimulating antibody. 10-year-old girl with Graves' disease on carbimazole. What is carbimazole? Carbimazole is methimazole, is anti-thyroid drug. Which one of the following is the most serious side effect? So, most serious side effect of anti-thyroid medication. Is it fever? Fever is true. Rash? True. Granulocytopenia? True. Arthritis? True. So, all of them is true. So, is this question is wrong? No. The question asking most serious. So out of these true side effect of antithyroid. So this is, you can learn from this question, all these are side effect of antithyroid. Somebody asks you, what are the side effects of antithyroid? All of these are side effects. So the answer, most serious one is granulocytopenia. Granulocytopenia is the most serious one. Antithyroid medication, we have two. We have either methimazole or propylthiouracil. Both of them are available, but first line of medication or first choice is methimazole. Why not propylthiouracil? Because propylthiouracil is associated with the risk of severe hepatotoxicity. So nobody use propylthiouracil as a first line. Side effect, we have minor side effect, rash, fever, arthritis. We have serious side effect, but alhamdulillah, rare, The serious one is rare. What are the serious one? Agranulocytosis or hepatotoxicity. If remission does not occur following antithyroid medication, second line of therapy is either radioactive iodine or surgical subtotal thyroidectomy for Graves' disease. 11-year-old boy confirmed to have Graves' disease has presented with severe proptosis, tachycardia, fine tremor. Which one of the following is the most accurate statement? So we have Graves with severe proptosis. And the question, most accurate statement. Radioactive iodine therapy, in this case, is the first line of management. For sure, wrong. In children, we don't use radioactive iodine as a first line. It is second line. But also he has severe proptosis. So severe proptosis, there is a problem from radioactive iodine in a child or adult with proptosis make it more worse. So the proptosis will be more worsened by radioactive iodine. So definitely A is wrong. BTU is more preferable than methimazole. This is wrong. We said methimazole is the first line, not propathyrosine. Granulocytopenia is a complication of antithyroid medication. Yes. Granulocytopenia is a complication. Surgery is a good option for this child. Yes. So we have either granulocytopenia is a complication or surgery is a good option for the child. We select surgery because here management. They want management rather than what is side effects. So the management, the most accurate management or appropriate management is surgery because the child having severe proptosis and not responding to antithyroid medication. And this is theoretical part about Graves' ophthalmopathy. And whenever we have severe proptosis, we might also, in addition to antithyroid medication, to give steroid 1 milligram per kg per day for 4 weeks, and then we taper the steroid over 2 to 3 months in only cases of severe proptosis, not in any Graves with proptosis. Graves with proptosis, we don't give steroid. Steroid only in severe cases of proptosis. This 16-year-old boy with thyrotoxicosis presented with bilateral, firm, non-pitting asymmetrical plaque over his legs. So what do you think of this skin changes over his tibia? Yes, you are right. Pretibial myxedema. And this is one of the skin manifestation of Graves' disease. Pretibial myxedema, what is called thyroid dermopathy. It could happen, but alhamdulillah, rare. This term used to describe localized lesion of the skin because of the position of hyaluronic acid and usually in front of the tibia. But it may occur anywhere, maybe ankle, dorsum of the foot, knees, shoulders, elbows, upper back, nose, neck, anywhere. But the commonest site is pretibial. Is nearly always associated with autoimmune thyroid disease. So this is also another autoimmune infiltration of the skin fiber. 6-year-old girl referred with growth failure, poor appetite, recurrent abdominal pain, and stool was described by the mother as thick custard, in addition to vomiting. All these manifestations, of course, manifestation of celiac disease. The question, not the diagnosis. The question, What is the appropriate most confirmatory investigation? Bone age is a good choice. In celiac, bone age will be delayed, but it's not most confirmatory. Anti-tissue transglutaminase antibody, very good, but this test is screening test, but the question wants most confirmatory, not most screening or most useful. If they said most useful, we'll select anti-tissue transglutaminase. But here, most confirmatory. Most confirmatory is jejunal biopsy. So the correct answer is jejunal biopsy. Serum iron ferritin, of course. Anemia, iron deficiency anemia is one of the manifestations of celiac, but it's not the most confirmatory test for celiac disease. So remember, if you have a child presented with abdominal distension and short stature, please think of celiac disease. Celiac disease not usually comes with typical presentation. All of us should know that diseases can come with typical presentation or atypical. Celiac could come atypically only with short stature or with short stature and abdominal distension. Celiac disease may exhibit no usual findings on physical examination. It's not necessarily to have abdominal distension, maybe normal abdominal examination. So if you have a child, normal abdominal examination and short stature, also think of celiac. But short stature and distended abdomen, most likely to have celiac. Sometimes distended abdomen, sometimes you have muscle wasting, sometimes you have features of malnourished, but not always. And as you know, celiac disease, the treatment of choice is strict gluten-free diet. This is the problem of celiac, needs a strict gluten-free diet, not like diabetes. Diabetes, sometimes the children with diabetes can have some sweet, not a strict diet or sugar-free diet, but in here, in celiac, should be strict gluten-free diet. Before we do IgA anti-tissue transglutaminase antibody as screening, we have to be sure that the total IgA level is normal, because we could have deficiency of IgA. Total IgA will give you false negative screening for celiac. So please do IgA, total IgA level, before you do IgA anti-tissue transglutaminase antibody as a screening for celiac. And of course, if you have it positive, we cannot say this is celiac till we have upper endoscopy with small bowel biopsy to confirm the celiac disease. Okay, what we'll do if we have a child suggestive of celiac, or we need to screen for celiac, and this child unfortunately has IgA deficiency, so we cannot do the screening, the usual screening with anti-tissue transglutaminase. What will be the situation? There is a test only if you have a child with total IgA deficiency and suggestive and history or examination suggestive of celiac. You have to do something called IgG DGB. IgG DGB. What is DGB? Is deaminated gliadin peptide. This is test only should be ordered in children with suspected celiac and IgA deficiency. By this, we end up our second part of endocrinology review MCQ. Good luck for all of you. I hope was useful for everybody. See you again, inshallah, in third part of pediatric endocrinology review MCQ.